Okay, well, coming from Oklahoma City, I'm definitely in the urban situation, but my background, I did start out 30 years ago in Texas. For those of you, I smiled when I saw North Texas up here. I was an aide. When you walk in the door, you didn't even have to be certified, and for nursing homes in Texas while I was going through my RN. And I did go to UT. I try not to say that too loud in Oklahoma, but I know we have some Texas folks here. I also, from there, I have done home health, and I worked med-surg while I was in Texas. All the time, my primary love and focus has been geriatrics. So home health and hospice, I had stayed with the elders. I prefer the elder population in geriatrics. And then coming to Oklahoma, I did hospice care, which transitioned now into long-term care, where I was a director of nurses and now an administrator. So I kind of have a little bit of a glimpse into everyone's area that you serve, and I know all of us are here because why? We love people, and we love to see them get better and have a quality of life. And with your heart, it's not a job for everybody, it's something that you have your heart in. And so today we're going to look at it from the perspective of transitioning care from the hospital setting into long-term care or into your skilled. When you send them from the hospital, they go into skilled nursing, and that is for the rehab therapy. And there's some challenges, and I think this is so great because each of us will get to see, you've heard from different voices and perspectives. It's whatever a part of the profession that you serve, what part of the community, whether you're serving in acute or post-acute, we all come with a different perspective. And sometimes in those perspectives, we don't quite understand where the other group is coming from, and it can cause frustration with each other. So it's really good when you get to hear all the different problems and challenges that you have within your part of the medical profession as to how we're going to transition folks over from one to the other. So the objectives for today is to apply the knowledge and to develop a quality assurance performance improvement program. QAPI is what CMS wants to call it. That is what they recommend, but most everybody says QAPI. For reducing avoidable hospital readmissions. There are hospital readmissions that are absolutely not unavoidable. They need to go to the hospital, and our teams that are there at the hospitals, they need those teams. They need the equipment, they need their knowledge, they need their experience and expertise in the acute setting. We also need to we're going to assess challenges that hinder a successful transition of care, and to look for tools to improve communication between healthcare providers. I know that the tools that we had used was the Interact 2. Has anybody here had the privilege of being part of the Interact 2 pilot program or learning about Interact 2? Well, we'll discuss that, and I have some examples, and it's a great resource for you, both for you can use for long-term care as well as there's something you can always glean from. If you're in a post-acute setting, you really need to look at and understand your hospital readmission rate and know why it is so important. If providers who are receiving patients from the hospital, if we send them back because they're so ill or we don't have the resources in the skilled nursing setting, they come back to you, and within 30 days, what happens? You don't get paid, do you? And that is, and if you have a community that you are constantly wanting to refer people to, and they're sending them back over and over and over, you all lose money, and are you going to want to refer to that place anymore? No. And it's probably not the first time that's happened. One of the challenges that you have being in rural is that you may not have very many choices. And so what if both of your choices have a very high hospital readmission rate, and that's all you got? So you're going to have to send them there, and meanwhile you are doing a lot of acute care services without any payment. And that is a really bad place to be in. And according from CMS coming down the pipes, it's going to be in skilled nursing. Medicare is not going to pay us as well, and that will go over onto home health if our numbers in our readmission rate are not successful and begin to lower. It's going to go down. And next slotted on the list will be the long-term care, skilled nursing, and again, home health. So we're all in the boat together. It behooves all of us to work together and to transition our patients swiftly, carefully between one another. So we're also, in order to start, you have to have a starting point. So the first thing to do is to determine your hospital readmission rate and know where it is. I saw when North Texas, they have their readmission rate. They have made great strides in that. You don't know how to set a goal to where to go if you don't know where you are. So you really need to establish that baseline. Get a benchmark from your communities around you. See what they're, for this area, your benchmark is going to be very different than mine in Oklahoma City, where we have many hospitals and a large population, not only to refer out to from the hospitals, but a large population of a variety of patients. And some of the patients that go, you have hospitals that are specific just on cardiac or just specialize on orthopedics. They specialize on one area, so they know where they go. They know that they're going to send all of their post-hip, those who've had hip replacement, they're all going to go to the XYZ skilled nursing, because they know that's where they're an expert at. But they know they're not going to send those who've been there with diabetic complications, because that's not where they do better at PDQ. So that is something to look at. The other thing is we want to then next look at developing a quality assurance and performance improvement system to track and reduce readmission rate. I really appreciate North Texas, because that's exactly what they did. They began to look and establish their information so that they knew where they stood. And then they developed that QAPI program, that quality assurance, and they did their root cause analysis, and they began to look at the reasons as to why. Why are we having this rate? How can we do better? Because all of us can always do better. If you get to where the point you think you've reached the top and there's nowhere else to go, you've fallen behind. Because we're constantly growing and changing, especially in this field and with technology. Okay. Determine, on the root cause analysis, we're going to determine if the readmissions were avoidable or unavoidable. Again, we said that there are avoidable and unavoidable. Some things you have to send them out. And that's what that root cause analysis is. If you look through and you find out that in your root cause analysis, everyone that goes back is, which we did, for example, we realized in our root cause analysis that it was all because of not eating and drinking, and the dehydration factor that came in from folks when they got out of the hospital were so ill and so weak, they didn't take in the nutrition that they needed. They've pulled their PICC line. IV access is not often even one of the services offered in skilled nursing. And so when you have that, we'd send them back, and before you know it, they're dehydrated and they're sick and they're confused and everything else that can go wrong. They're weak, they're deconditioned even more, and then they came back to us. So we performed our root cause analysis and actually determined, well, we got IVs. Maybe we need to do something about that. And we'll talk later about some of the things that we did and how we changed so that we could improve and no longer have that as a deterrent for us or a challenge. And then we focused on those that were avoidable. If it's unavoidable, don't spin your wheels on it. If they have an acute heart attack out of the blue, they're there for pneumonia, there's not much you may have been able to do that for that person at that point. It happened, they had a heart attack, because they didn't even come to you for cardiac reasons. It was a secondary. But focus on what you can. And the number one thing people go back to the hospital for is confusion and falls because of their medicine and their confusion. We discussed where our meds and the med errors are so prevalent because you have docs have been changing the medicines in the hospital, then they come back to the long-term care, and if those orders are not reconciled, you wonder why, oh my gosh, they got 2 of those pills. They got a generic and a name brand, and now I've just doubled up. Or why are they on sliding scale? They're not even a diabetic, because many hospitals' protocol now is to use sliding scale to keep blood sugars in line from their medicines, and they get on steroids for respiratory, their sugars go up, and they find a stable blood sugar helps their wellness along. And it helps them to heal and get better quicker. So then they come back and get discharged, and we have all these diabetic orders. We have ICD-9 code with the 25-250.0, and you're thinking they never had that one before, and you can't find any information that even says they're diabetic. So those are where you can dig down and drill down into your root cause to determine where to begin your program and what is the problem. And then the most important thing is to tackle one root at a time. If you know you have transportation issues, as we heard earlier, and maybe you have problems with getting your equipment in from the hospital to the skilled, trying to bring that equipment in, you want to focus on one. After they got their taxi cabs and they got the bus line and they made all their transportation, they met that challenge, they were successful, then tackle the next route. And then you want to start simple and to assure success. So begin with the easiest one, then celebrate that success and celebrate with your team because you did it. And you did great and you should be proud of that. And then, hey, let's tackle the next one. You also want to become proactive, so to establish an admission protocol. And I know where we were, one of the biggest challenges that we had was the admission process. And going from the hospital, where the acute setting, your job is to fix their acute problem, get them well to overcome that, and then they go to skilled nursing or they go home with home health to recover further. They're well enough, the acute issues are resolved to a point where they're able to be managed and strengthened somewhere else, no longer needing the hospital. And with our admission protocol, one of the things we noticed was the lack of understanding between the hospitals and the skilled nursing. And we had say an order that would come in for IVs, and they'd say, can you do this admission? The doctor just did rounds at 7 o'clock at night and they've got an IV, or they need a CPAP, or they need this medicine immediately from the pharmacy, and they need Coumadin, and we give our Coumadins in the evening, and you're waiting for your meds to get there, and your medications get delivered at 2 a.m. from the pharmacist. And so you're already behind the 8 ball by the time they give you a referral. And so on our admission protocol, we began to change how we admitted. And our biggest day when we did a root cause analysis was on Friday. All the hospitals are moving everyone out. They are going over to skilled nursing on Friday, and they have great reasons why. Now from the skilled nursing, that doesn't make sense. How come they couldn't have gotten us earlier? Why didn't they let us know? Well, there's a whole lot that goes on that we don't understand what each other does. Everybody's heart is to do the best thing for the people that we are caring for and serving, and yet sometimes with each one with different agendas and protocols, we collide violently in the middle to the demise of our people, of the patients that are getting caught in the middle of that. So on our admission protocol for Fridays, when we started, that was our first baby bite of the root, one of the roots that we took. We decided that we were going to only accept a patient over to skilled if we had all of their orders prior to 2 p.m. So why? Well, Who here who has skilled nursing, do you have a pharmacy 24 hours available in your building or on your complex? Or has ability to get a CPAP or a BiPAP or a low air loss mattress, or to get the DME tools you need, or to get your IVs? So because of, even in the urban, our limitations to have a physician available if you should need anything. So to be right there on board, especially with someone who is ill, that really put us at a disadvantage. And many times the group that we were in Tuesday, they were all long-term care. And when we went around and were talking about this, do you know they denied all of their referrals? So if you're a case manager or a nurse and you're in the hospital, you're in an acute care setting, and you know you've got to move these folks out. You've completed what they're done with you. You've addressed their needs. You've done a great job. They're well enough to move on, and no one will take them for you. How frustrating is that? Not only is it a financial liability, it's a big frustration, and it's extremely stressful because of the fears in long-term care, because we do not have access to all of the equipments and medications and the personnel as you do. On 11 to 7 at night, you have maybe one LPN in that whole building with some really sick people that just got out of the hospital and are still coming out of their acute illnesses, and that can be very much a strain. So what is that nurse going to do when she calls the doctor at 2 a.m.? Send them back. So we send them back, and then guess what happens? You all don't get paid if it was pneumonia or an acute MI or CHF that exacerbated in a day or two or in 30 days. So it goes over onto you. So it's really important that we had changed our protocol. And it worked. We informed hospital discharge planners and our case managers of our new protocol. Listen, we want to help you. You can send them anytime you want. You can discharge them Saturday night at 2 a.m. It's okay. But we must have the orders before this 2 p.m. magic number for us on Friday, because the doctor's office shut down half day. Most of our DME, after 2 o'clock, you've lost your window. Then you go to the answering machine and you put what you want on the answering machine, and hopefully by 6 o'clock they'll get to those menus or those messages. And so there's no guarantee you have your equipment out, in which we had one time that happened. We had somebody who had been a CPAP, could not breathe at all without it. We went, okay, we'll go ahead and take them. We didn't have the orders. They didn't get in till about 6 o'clock at night. We were not able to get a CPAP machine. So what do? You now have a person in your building with no access to help them breathe. If you say, well, I'll just keep them and keep them awake all night, so maybe we can, you can't do that. So what is your only hope, your only option? You send them back to the hospital, and who loses their money? You all do. And who loses your credibility? We do. And who suffered in the transition? The patient. We also educated our admissions and social services and nursing teams. Now, all of these, this is how we did. This is for our community. I'm looking from the skilled nursing point forward to the acute care setting. But you can take these and reverse them for you as well. So educate your admissions and social services and your nursing teams on those specific protocols that you have. And remember, the post-acute provider, which is the skilled nursing, has the right to accept or decline a skilled nursing patient. You have the right. It's frustrating. It is not actually something you may want to hear, but they do have the right to say, no, we can't do that. But be honest. If you know you've gone through and you've made every possible plan and thought of everything you needed to make it a successful transition, if you cannot successfully transition someone and you know you're setting them up for failure, has anybody here done that? really know your gut saying, oh, that's not a good choice, and you know what, you go ahead and do it because the beds are empty and you need to keep your census up, and the hospital, you want to be a good friend, and you want to help them out and help them move this person over, and so you say yes, and then you're up there all night long. If you've ever been a DON, and you may be the only RN around, so it falls on the DON, and you're up there all night long trying to put out fires. And then your only thing, if you can't manage it, is you send them back to the hospital, and that person has to be submitted one more time to an ambulance, to another admission, to another ER sitting, and to go through all that again. Establish a care coordinator. Now, in the skilled nursing, we have MDS case managers. Do we have any MDS case managers in here? Who does the MDS? They need a hug when you go back if you have them, because that is a job. That is sets the plan of care. It establishes, it assesses the person holistically. It builds how we're going to take care of them on our nursing plan of care. It also is what goes to CMS and bills Medicare. It is a very vital, most important document we have. And we're at Baptist Village, the care coordinator is that MDS person. Why? Because they get the information from every group, from therapy, from lab, from nursing, from the physician. Everything is filtered through them. And so you need someone in your organization, a nurse that is able to be that care coordinator, that can be filtered through, and they can see that big picture and go, gosh, I know this happened, but I just was talking to therapy, and they said that they were really, really unsteady today, and yesterday they weren't. So then they can call the nurse who says, oh my goodness, they just started a sleeper for the first time last night, and they got him up early, and that's probably why she was wobbly. So they're able to tie the pieces together every day. Also, your medications, treatments, and equipment, you want them ordered so that they are ready in conjunction with the arrival. And that is really important, because there is nothing worse than not being planned. And we had a shame on us when that CPAP machine did not come. It was not there. It said it was going to be there, but it did not show up. And there is no way on Friday night, even in the city, we were calling, pulling strings, our friends at hospice, anybody in home health, calling the hospital, and we were sunk. And the only choice we had was to say, I'm so sorry, and send her back. And you don't want to do that. Notify the physician in therapy. That's another way to be successful. If you have a medical director or a physician that is there, the one who is with if you have one, if you're fortunate, sometimes you have multiple. In a small town, you may have a variety of doctors, but if you could notify that one physician who will be their primary to let them know, hey, we've got someone coming in. This is just a brief couple seconds about what's going on. They have been really struggling with nausea, so we have this on board, but I just want to give you a heads up. Or we have ordered the CPAP or the BiPAP, and I'm just letting you know it's not here. So he may be all ready to have you a backup plan. Also, therapy needs to know. You do not want therapy falling through the cracks, because you only get 3-day grace. That's all Medicare gives you, and then you're wasting them when you don't need to. And you want therapy to be there to say, we got an admission, be ready to do an evaluation, because this person's really going to need that. Also, anticipate the potential concerns related to the diagnosis and already have a plan to manage them. I recommend, a lot of times you have protocols for certain body systems, disease processes, diagnosis codes. Very helpful. Anticipate the concerns. If you know they are diabetic, do you have the needles? Do you have the syringes? Do you have the medication? Do you have enough strips in your building? If you're not used to dealing with somebody with especially with those diagnoses, make sure. Inspect what you expect. Make sure that it's all there. Have the team on board. If you know you have someone with the PICC line, you've got your RN and your team available who's been trained. If they're out on vacation enjoying Cozumel on the beach and that's your only nurse you got? Are you going to accept somebody while she's on vacation with a PICC line? No. Unless, if you don't have anybody there you can qualify to get, or your doc isn't going to come out and do that, you may have to say no. So you need to anticipate what you have and have a game plan for it. This is what my mama taught me, and it's proper prior planning prevents poor performances. Always remember your P's. And so if you're thinking ahead and you're always planning for that what if, you'll be prepared if it should happen. So always think about that what if. And the patients that are in the hospital, they are needing us to what if for them. They're sick, they're scared, they're tired, they're ornery, they can get crabby, they hurt. We need to think of the what ifs. What if I discharge them over to skilled nursing and I know the doc is leaving at noon and it's 11:59 and I didn't get the heart script to send with them in the paperwork? That person is going to be in pain. And now when the receiving site, the skilled nursing, is going to be having to jump through hoops, dragging that doc off wherever he is and interrupting. He may be having to do rounds at the hospital or something else, which a lot of them tend to do on Friday. They leave a half a day so they can either catch up their paperwork or do rounds at the hospital, and then you have a whole mess on your hands. So you want to think ahead and plan for any unavoidable. Those that are providers in the acute care setting, we need to partner with them and be helpful. There is a lot we can do for them, and it's a simple thing, and one is expand our skilled services. Remember I had talked to you earlier back about the IV, and we would say, oh no, we can't do it. You've got to change your meds to PO before they leave. And well, why? We began to root cause analysis. Why can't we do that? Well, because we don't have the nurses qualified. Well, why? Because the majority of them are LPNs and their certification has got to be kept up every year. Well, why isn't it done? Well, because I guess we didn't realize it and we didn't have a class. So we brought in instructors. We got them all certified. Every year they go through training. We now have that. What was the second thing we looked at? Well, we can't get IV fluids. Well, why? Because the pharmacy closes and we're not able to get them there usually within that day. The next day is usually not a problem, but right away at that discharge. Well, why? Well, because we haven't had the orders quick enough to get it from them. Well, why? Well, we never told the hospital that we really needed them. If they could get them before 2, we could get them over to the hospital, or they could even fax that order, send an order over to the hospital. Whatever we get working out, we can get that done and bring that into our building so that we can be successful. So just in that simple, that was one of our first routes we tackled after we figured out our protocol, and then we met with the hospital. We began to tackle that. Now we take IVs. We have an RN on every shift every day, 7 days a week, so we can handle PICC lines. We have that has been met. We don't have to send people. If you have somebody in your hospital that's really sick and has pneumonia, or they have C. diff and they're on Vanco, so don't pull them off the IV and change over to oral, which may not have the same efficacy. Leave them on it. Leave the PICC line in. We'll take care of it. Leave the IV. We'll get that in so that person has the most successful chance and the best chance of getting better, especially when you're dealing with your MRSA, your VREs. You've got C. diff is running amok everywhere. That's a new thing. So what else did we do? We took 2 of our semi-private rooms that happened to have its own little bathroom in there, and because we have a long traditional building, trying to be modern in a traditional medical model, long-term care can be challenging. But we turned 2 of those rooms into isolation rooms. So you know what? I don't have to tell you at the hospital, I am so sorry, friend, but we cannot take this person because they have C. diff. So we changed our protocol. We changed with their symptoms. We give them a bedside commode. We have all these upon admission, and we assume everybody has that. We look for symptom-free. We check people. We don't have to worry if they come in with C. diff or MRSA. We have an isolation room, so we can move them in. Our no, now we have another reason we can say yes to you. And it was more of us looking at how can we help our acute settings? How can we help the hospital do a great transition of care? We got to step up our game. And you know what? It works. Who would have thought we could be able to do that? We still don't have a lab in our building. We still don't have a pharmacy in our building. We still don't have a DME in our building. We still don't have access to respiratory therapy and docs galore running everywhere in case we get in a crisis and we need a physician right on the fly for our hard scripts. We still don't have any of that, but we're doing it. And the hospitals see that commitment that we're doing to try to help them. They see that our readmission rate, by the way, for a whole quarter after we started this process has been 0. So we have not, if we bring in, our skilled neighborhood takes 18. We have 18, like we like to say, opportunities to serve 18 skilled guests. So we have 18. And in 3 months period, and we stay at 98% full, that's our average occupancy rate, we had 0. But do you see where we had been no, and now we're able to say yes, yes, yes? And now when we find ourselves saying no, you know what we do? We grab the whole team together again and say, why? 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 Well, because they have a wound vac. So, why? Well, we don't have one nurse who knows a wound vac. Hey, now I have friends at the hospital who see what we're trying to do. I call them up and I said, can we work out something where you can train and educate our nurses to run a wound vac and how to do that and be trained on it? They set up training. We went to our local friends at the hospital and they were so excited to partner with us. They see our results. They know that we have a good reputation, but that we are working very diligently to make us being successful makes everyone successful. And then our home health also went out and was wound vac certified because they would say no. And now we can go from the acute care setting from the hospital, and they can either go to home health, everyone's trained on wound vac, or they can come to us and we're trained on wound vac. So we've just crossed 3 items off our list. We worked with pharmacy to get our medications better, and now they hold a 6 o'clock delivery for us on Friday. It is on the message machine, but prior to that it was 2 period. 2 o'clock and you're kind of done, and you had to wait at least till the next day before you got it. Now they scan the calls for their skilled nursing. They changed their protocol that allows us to message in till 6, so they fill all the morning orders. Someone takes all the meds that come in till 6 o'clock, and that gives us a greater chance and success rate to get our IVs and medicines in. So you really want to know to communicate with the hospitals to discover how the post-acute, that's skilled nursing providers as well as home health, can meet the needs of senior adults. And see, I didn't say meet the needs of the hospital or meet the needs of the home health. It's meet the needs of the people that we serve. And it's those patients, those guests, those clients, those are the ones who make a difference. And the tighter we are and the better we are as being a team, the more that they will serve, and it will be a win-win for everybody. Now I want to go a few minutes into the resources for success. I have been with, I consider I'm like a part-time volunteer employee, I guess, for OFMQ. I always spout praises for them because they are the ones who have worked with our community over the years since I was a DON. Every new project that came down the belt, every new program that we were going to work on, we're going to do Saving Oklahoma Skin or working with restraint reduction and all those different things. We jumped on board with OFMQ. They are a wealth of information. Their website is really dummy proof. It is so simple to use because I'm not a high-tech girl, very easy to use, and you have access to so many tools and resources. Why reinvent the wheel? Work smart, not hard. Every one of you in here has mastered something. You all are experts in something. I may be an expert in something you're not, but you're an expert in something I'm not. And when we share and put that together, it's amazing the things that we can do. There are some tools, the S-bar, there's an acute care transfer log, and then you have the clinical pathways, which are just a sampling of what's in there. Our computer, we went electronic health records completely in all of our campuses. It was a huge endeavor, and we're now beginning with our assistance in living. But in putting that together, the Interact 2, this is one of the best software programs in the nation. It was actually rated as the top 3 for the nation for software for health providers. And it is incorporated in ours. So if you're looking for software and looking for electronic health records, a lot of the resources that you may like, you may not choose Interact 2, you may have something else, they may already be built into your software. The communication part, under the background and the communication to send someone from, this is looking from the perspective from the skilled nursing back to the hospital. It could also be tweaked for home health back to the hospital, but this is designed for your community to go back to the hospital. It's a little reminder note to get all the information so nothing is lost. Sometimes something as simple as a diet can make all the difference. We send them out and forget to tell you, oops, they're on honey thickened liquids and they must have ground meat or a puree diet, and you don't know that, and you just bring them a Coke because you're kind, and they said, oh, I'd love a Coke and I've had a rough day, and just like I would, you love who you serve, and you said, I'm going to make a difference, and you're all excited, you go out and get them a Coke and they choke and aspirate because you were missing that information. So it's a great little tool. We did find it a little bit laborious in gathering all that information, but we used it for a while, and what it did is it helped train our nurses to know how to have what information to gather. It was a great teaching tool. Our software now includes the Interact program, so while we're doing our charting, it automatically guides us through the process for that. But I shared where we were at the last place we were in, and those of you who may be the nurses or charge nurses have the experience of the doctors, especially in long-term care, because you don't have docs there at night. You're kind of all by yourself, and something goes wrong and they panic, someone doesn't look right, and they call the doc and they say, Doctor, Mrs. Smith is not breathing right. And he says, okay, what's the vitals? Well, I don't know. Well, what medicine she's on? Oh, rats, I need to go get the chart. What's this? So the physician then would call me and say, your nurses need training. When you talked to them, they knew what to do. They just didn't do it at that moment. They felt panicked. They were a little nervous. They were there by themselves, and all they wanted is that doctor. So for me, what I did is I told the nurses they were not allowed to call the physician until they talked to me first. So as soon as they discovered something, you call me. I don't care if you wake me up at 3 a.m. You call me. And they'd come in and say, Mrs. Smith, Michelle, she's not breathing. And I would say, what's the vitals? And they said, I don't know. I said, go get them and call me back. And anything else you might think of you might need, get that information too and call me right back. So they'd call me back and they'd say, you know what, I've got the vitals, I have this. Now this isn't an acute person. This is just someone who's having, otherwise you'd call MSIP. I'm not saying they're turning blue and not breathing. I'm making a caveat. I'm just saying they're having some changes to their respiration status. And so in that process, she'd call back and said, I got the vitals, they're stable, everything's good. And I said, great, what do the lungs sounds like? And rats, I forgot to get that. Well, go back. So they go back. Well, you know, it takes one time calling me all night long, every 5-10 minutes to get that information. Guess how many times she had to call me after that to be reminded on what to do? 0. That's all it took. And that form basically is a walk step. So whether you do a written scenario at one of your training team meetings and you have them work their way through the process, it clicks in their brain what you need to do. Now it's an automatic thing. They know if they're having an acute MI, they have a PRN order for some nitro, they've given it, and if the PRN says give, wait 5, give, and then you call the doctor after the second, then that's what they do. Or after, call IMSA after, whatever the protocol is they know how to follow that, and they're not afraid to call the doc when he says, well, did you give her a nitro? Oh, I forgot. You know, it reminds them and cues them, did you give her some clonidine because her blood pressure? Oh, I forgot to do that PRN that you've ordered. So I woke you up at 2 a.m., woke the doctor up when you forgot that he did leave you some PRN orders for that. And then again, that partnership. Adopt a clinical pathway. On the clinical pathways, if you look in, you should have 2. I think one is the common, the mental status change, thank you, and urinary tract infection. You know, for skilled nursing and long-term care, if you pull out your little watermelon book as we know it, the survey readiness book for the regs, UTIs, it's the 4 out of 5. They must exhibit 4 out of 5 symptoms. Mental changes are not enough on its own to warrant treating with antibiotics. So look at your regulations, know your rules, teach your physicians, know that, because we tend to panic and automatically send them out for a UTI, and there's probably nothing more. I worked ER for a couple of years. I was one of the weekends who did the 16-hour weekends, and I thought, oh my gosh, they're just dried out. If you would have given them a little water or given them something to drink because they just got over a cold and they haven't felt good and they've had, you know, some anticholinergics on board and they're dried out, and you could have probably prevented that. But if you look at the regs, there really is 4 out of 5 symptoms and 3 out of 4 if they have a Foley catheter in. So know that and be a little confident. These care paths actually walk you down. It says, do they have painful urination, lower abdominal pain? Take the vital signs. That's always first. It's amazing. They forget sometimes just that little reminder. Oh yeah, get the vital signs. Then you go down to, was any of these criteria met? If no, you go to the next one. What it does is it really helps give confidence and reassurance to nurses who are in the long-term care setting, the skilled nursing, possibly even in an LTAC that may not have as much access to the hospital. Gives them a sense of reassurance that, hey, it's okay, I don't have to panic, I can go down through these little things. And then anywhere it points to a yes, that's where you go. And then it tells you follow your pathways down. And there are several. You can purchase these like $12.99. They're laminated with a ring. And I just have one at each nurse's station. They can pull them off if something's going on and flip through them. It prevents that panic. And why is that important too? Because especially home health nurse, you guys are out alone in the field, aren't you? You get out there, you don't even have a buddy around. The only thing you've got is somebody by phone. You're all alone in that home. And it's nice if you have one of those little pathways in the book. It just kind of calms. Oh, it's okay. Doesn't have this. It's not really, she's not showing this. So maybe I can try this or call the doctor or not panic. So they are really good. They're available on Interact. You just click. It takes you right to the shopping cart. And they're very nice to have. And I recommend those. They help anybody, anywhere. And you may have your own protocol. If you have evidence-based clinical pathway protocol, get them out there where your nurses can get to them. They're very helpful. And they have everything ready because you want the physicians to know, have confidence in us. You know, we're professional and we need to have all of our ducks in a row before we notify that physician so he can make the best, most intelligent medical decision for that person based on the information that we give them. So we need to have credible information for them. Okay. And guide the nurses, let's see, clinical pathways. They also guide with appropriate interventions based on symptomology. I don't know if I brought that out. So it is all symptom-based. It is not disease-based. Because remember, as nurses, we're not able to make a diagnosis, a medical diagnosis. We can make nursing diagnoses, which are based on symptomology, alteration in. impairment in. And so it kind of guides us with that in mind. It is designed for your nurse to follow that. And again, it prevents hospital readmission, which is going to affect all of us, both home health, long-term care, and skilled. Send her to the hospital. Develop or adopt information gathering tools for a nurse to compare the before calling the physician. That's your SBAR form, which you have in there. And then it also will help our physicians. I think I covered that. And then on the post-acute setting, the challenges we looked at, and I discovered from the groups, is that we have lack of availability of our ancillary medical needs on site. And so that is really important to have on your card or on your information you share with your hospitals what you have and what you don't. We had a group the other day that they really had access to that pharmacy. That was not a hindrance to them. The pharmacy in town could fill their prescriptions anytime, any day, any IVs, and so make sure you let people know. That also kind of sports and makes you shine out in your community to let them know what you have, and then you have a successful transition. Limited resources for the charge nurses. Educate. I am a big proponent. You're only as good as your education. Educate your nurses. If you have a team, invest the money. You're here today, invest the money to educate people. Educate your nurses. Give them communication classes. It does not have to be expensive. It does not have to be lengthy. There are little programs out there, and even with OFMQ, Interact 2, there are different programs. Hospitals have amazing, they have the resources for amazing educational programs. Partner with them. I'll bring lunch if you, let 3 of my nurses come in and sit, or I'll help with this, or can we join in and learn that? We want to be able to take people that have a wound vac. We have to tell you no all the time, and I don't want to tell you no anymore. So can we come with you and come on over? And so they went in and joined in at the hospital and learned that. Home health tagged along with them. Partner with you. Share each other's information. When you have a great teaching opportunity in your community or at your place, open the doors. Send them out to those that you work with and network with. Say, hey, I just want to let you know that. That is one thing that we have really worked on in Oklahoma City area, is building that network. Everything that goes on, any teaching programs we have or events, the hospital has, our geropsych, and home health, hospice, we all send emails in the flyers. You put the flyer as an attachment and just blanket it out to everybody. It's really handy. You may not choose it. It may go by and go, thanks, and just delete it. And you may go, wow, I need that one, and that nurse needs it, and I'm going to send them over. And I know this nurse and I know this physician. If he's going to teach that subject, it's going to be awesome, and I want to get as many of my people out there as possible. So to sum it up, know your hospital readmission rate. That's your start if you're in long-term care. You probably might start keeping those records for home health if you're not. Develop your QAPI system to track and evaluate the hospital referrals and readmission. Again, know your friends. You've sat with people who you've discussed at your table. Exchange cards. Work with that. Find a root cause of your hospital readmissions and become proactive. Get your team involved. Get your community involved. Everyone wants to be successful. And I'll tell you what, the way our world is going and with technologies, we're not islands anymore. We are all connected together. We've got a person that is our patient that goes from one entity to the other. You're not alone. You don't just drop them off. We're all paid. We're going to be strung along for payment. Everyone's success is a success, as all of us have to be successful, not just one. Expand your skilled services, and that I really want to recommend. Don't be afraid. Look at those ways. Take something tiny. Find your hospital. Say, what is the majority of the people that you get that that are discharged to skilled services? What is your number one diagnosis, and how can we help you accept them and receive them? Utilize your resources, adopt clinical pathways, develop information gathering tools. They're all there on those resources I gave you and amongst each other. Build relationships. That is so important. And remember, it's by taking a proactive approach to improve the transition of care between the acute and post-acute care settings that will reduce hospital readmissions that are unavoidable and enhance the lives of those being served. Thank you.